Encephalitis. Encephalitis is an inflammation of cerebral tissue, typically accompanied by meningeal inflammation that is caused by a viral infection. It presents as either acute viral encephalitis or post-infectious encephalomyelitis. Pathophysiology and etiology. Number 1. Acute viral encephalitis, accounting for the vast majority of cases, is caused by a direct infection of the gray matter containing neural cells. Results in perivascular inflammation and neuronal destruction. More common in children and is most commonly caused by a herpes simplex virus and to a lesser degree by the arboviruses. Herpes simplex type 1 is responsible for almost all cases of herpes simplex encephalitis in children and adults. Herpes simplex type 2 is more common in neonates who are born to mothers with this infection during pregnancy. Number 2. Post-infectious encephalomyelitis follows a viral or bacterial infectious process, but organisms do not directly affect the neural tissue in the white matter. However, perivascular inflammation and demyelination do occur in the cerebral tissue. The incidence of post-infectious encephalomyelitis has decreased considerably with immunization against measles, mumps, and rubella, and the infrequent administration of vaccines due to the eradication of smallpox, rare in infancy. The most common cause is the respiratory or GI infection 1 to 3 weeks before the acute onset of encephalomyelitis symptoms. May be caused by specific species of mosquitoes and ticks, arthropods, which may be seasonal and geographic host. Example: California encephalitis, St. Louis equine encephalitis. Number 3. Herpes simplex encephalitis may result from reactivation of the virus that has been dormant in the cranial and other ganglia or to reinfection. Direct spread to the brain by the olfactory and trigeminal nerve is suspected with herpes simplex virus type 1. Number 4. Cytomegalovirus encephalitis should be considered in patients who have advanced HIV infection, have evidence of the cytomegalovirus in the other sites, and have progressive neurologic deterioration. Number 5. Toxoplasma encephalitis is the most common cause of intracranial mass lesions in patients with AIDS. Clinical manifestations. Number 1. ICP may result in alteration in consciousness, nausea, and vomiting. Number 2. Seizures may be present. Number 3. Motor weakness such as hemiparesis may be detected. Number 4. Increased deep tendon reflexes and extensor plantar response are noted. Number 5. Fever may be present. Number 6. Headache may indicate signs of meningeal irritation. Number 7. Bizarre behavior and personality changes may present at onset. Number 8. Hypothalamic pituitary involvement may result in hypothermia, diabetes insipidus. Number 9. Neurologic symptoms may include superior quadrant visual field defects as aphasia, dysphagia, ataxia, syndrome of inappropriate antidiuretic hormone, and paresthesia. The syndrome of inappropriate antidiuretic hormone, shortly SIADH. SIADH. Diagnostic evaluation. Lumbar puncture with the evaluation of CSF is performed to detect leukocytosis, increased mononuclear cell pleocytosis, increased proteins, and normal or slightly lowered glucose. Polymerase chain reaction (PCR) analysis of the virus DNA and the detection of intrathecally produced viral antibodies are essential in diagnosing the specific virus. Example: herpes simplex virus, cytomegalovirus. Arbovirus specific IgM in CSF and a fourfold change in specific IgG antibody are diagnostic for arboviral encephalitis. Number 3. EEG may demonstrate slow brainwave complexes in encephalitis. Number 4. Gadolinium enhanced MRI differentiates post-infectious encephalitis from acute viral encephalitis. Enhanced multifocal white matter lesions are seen in encephalomyelitis, which may remain for months after clinical recovery. Herpes simplex virus encephalitis typically has medial temporal or orbital frontal lobe inflammation and necrosis. There may be low density abnormalities in the temporal lobes. Cytomegalovirus seen in patients who have advanced HIV disease may have enhanced periventricular areas. Number 5. Brain tissue biopsy indicates presence of infectious organisms. Management. Differentiate acute viral encephalitis from non-infectious disease such as sarcoidosis, vasculitis, systemic lupus erythematosus, and others. Number 2. In patients who are immunosuppressed such as HIV positive patients, differentiate acute viral encephalitis from cytomegalovirus encephalitis, toxoplasmic encephalitis, and fungal infections. Patients with cytomegalovirus may be treated with ganciclovir, cytobin, and foscarnet, commonly used to treat cytomegalovirus retinitis in HIV positive patients. Pyrimethamine, daraprim, and sulfadoxine are commonly used to treat toxoplasma encephalitis. When encephalomyelitis develops, supportive care is indicated because there is no known treatment. Corticosteroids may be used. IV acyclovir over 10 days to 3 weeks duration is indicated for herpes simplex virus. Mothers who have genital herpes simplex may be treated with acyclovir during the 3rd trimester to avoid shedding the virus to their babies. 4th, anticonvulsants manage seizures. Complications. Sequelae of the herpes simplex virus may cause temporal lobe swelling, which can result in compression of the brainstem. This virus may also cause aphasia, major motor and sensory deficits, and Korsakoff's psychosis, that is amnestic syndrome. Korsakoff's, Korsakoff's psychosis. Second one, relapse of encephalitis may be seen after initial improvement and completion of antiviral therapy. Number 3, mortality and morbidity rates depend on the infectious agent, host status, and other considerations. With herpes simplex and the mortality rate is approximately 30%. Thank you.